Severe hypertriglyceridemia is when serum triglycerides are greater than 500 milligrams per deciliter. The reason why managing severe hypertriglyceridemia is important is because it is associated with an increased risk of pancreatitis and cardiovascular risk. The patients who get pancreatitis related to triglycerides tend to have higher rates of organ failure and overall morbidity compared to other causes of pancreatitis. And how do triglycerides lead to an increased cardiovascular risk? Of course, patients who have elevated triglycerides have other reasons, like metabolic syndrome, that might make them more susceptible to cardiovascular disease. But when triglycerides are high, you will need more VLDL particles or more trucks to carry all of that fat and cholesterol around the body. More trucks means more of a traffic jam in the blood vessels. And on top of that, triglycerides and triglyceride remnants are pro-inflammatory, which we know plays a big role in cardiovascular disease pathology. When you have a patient with elevated triglycerides, first you should think about secondary causes or other driving factors. We can group these into four big buckets. The first is lifestyle. Do they drink alcohol? What is their diet like? And do they have a sedentary lifestyle? Next, we'll look through their medication list. See if any of these medications might be contributing, including atypical antipsychotic agents, glucocorticoids, oral estrogens, HIV protease inhibitors, or on the inpatient setting, propofol. Then look through their one-liner and see if they might have the following conditions or need to be screened for them. This includes nephrotic syndrome, hypothyroidism, Cushing's syndrome, or inflammatory conditions. And now lastly, we might need to think if genetics are playing a role, which we will get to in a little bit. Now we can consider management, including both lifestyle factors and medications. In terms of lifestyle, a very low-fat diet is key. It's also important to counsel our patients about including high amounts of fiber and a low-carb diet, particularly limiting those refined carbohydrates. And of course, avoiding alcohol consumption. Additionally, weight loss can lead to a significant triglyceride reduction as well. These patients will often need medications as well. First, let's consider statins. The ACC and AHA guidelines recommend a statin for individuals between 40 and 75 years old with an elevated 10-year ASCVD risk greater than 7.5%, with persistent moderate hypertriglyceridemia, so that is between 150 and 499 milligrams per deciliter, or individuals with severe hypertriglyceridemia defined as greater than 500 milligrams per deciliter. The benefit to starting a statin in these patients is, of course, that we can reduce their cardiovascular risk. And with a statin, we can expect patients to drop their triglycerides by about 10 to 30%. Next, we will consider omega-3 fatty acids. These medications have both a significant triglyceride reduction and an ASCVD reduction benefit. Notably, for these medications, we should be using a prescription strength formulation, predominantly with EPA or eicosapentaenoic acid at doses of up to 3 to 4 grams per day. You can expect about a 30% reduction in triglycerides. Lastly, we'll consider fibrates. These medications are first line in preventing triglyceride-related pancreatitis in patients with severe hypertriglyceridemia. Fibrates do not provide an additional ASCVD benefit when added to statins. With these medications, you can expect about a 30 to 50% reduction in triglycerides. And now let's discuss a genetic cause of severe hypertriglyceridemia known as familial chylomicronemia syndrome, or FCS. Chylomicrons are triglyceride-rich lipoproteins that are synthesized in the enterocytes after a meal. We should suspect FCS when we see fasting triglycerides that are greater than 880 to 1,000 milligrams per deciliter in an individual who might not have significant secondary risk factors for elevated triglycerides. So these individuals might be thinner and have maybe tried triglyceride-lowering therapy in the past without significant response. To date, there are 2 FDA-approved medications that target ApoC3, which is involved in the lipoprotein lipase pathway to help clear triglycerides. The first of these medications is olezarsen, which has been shown to reduce triglycerides by about 40% compared to placebo, and plozasiran is the second one, which has been shown to decrease triglycerides by 60% compared to placebo. So, to summarize the big takeaways, severe hypertriglyceridemia should signal us to search for secondary causes, act quickly to prevent pancreatitis, and reduce long-term cardiovascular risk. Really counsel the patient about their diet and activity, start or intensify statin therapy, and see if they may benefit from an additional medication, such as a prescription-strength omega-3 or a fibrate. And when levels are extreme or refractory, think genetics. The goal isn't to just lower a number, but to change outcomes.